welcome everyone to our pregnancy and transplant webinar. My name is Candice Coghlan, and I am the Education and Outreach Coordinator at the Center for Living Organ Donation. And we are incredibly grateful to have Lisa Coscia here with us from the Transplant Pregnancy Registry International, who will be presenting with us today. Again, for anyone who is new on here, I ask that everyone leave their video off and mute yourself for the duration of the presentation. And then at the end of the presentation, we will ask you if you'd like to turn on your video and ask a question. You're free to please put your questions in the chat throughout the presentation as well, and we will monitor those. And we will have lots of time at the end for questions for Lisa and myself. So I will hand it over to Lisa to introduce herself.
Great. Thanks so much. My name is Lisa Coscia, and I'm the Senior Research Coordinator for the Transplant Pregnancy Registry International. And I've been doing this a long time, so I'm happy to answer questions. And if I can't answer it today, I can always grab your email address, or you could email me directly. My contact information will be at the end. I've been involved with transplant for over 30 years and done various roles, but have been with the registry for the last 25 years. So I'm actually going to turn it back over to Candice, and she is going to tell us a little bit about herself.
Thank you so much. So not only do I work for the Center for Living Organ Donation, but I also have a personal connection. So back in July of 2008, I was a regular 24-year-old going to university and dating then boyfriend, who is now my husband, for only about a year. You know, everything was very normal, what you would expect of a 20-some-year-old's life, until I thought I had a very, very bad flu. And so I had been losing weight and wasn't feeling very good. And then my mom, with her mom instincts, asked me to go to the hospital to get some extensive blood work done. So I did go during the afternoon, and by that evening, the emergency room was calling me, telling me to get to the hospital because they were worried. They didn't tell us much else. So got to the hospital, and several hours of testing later found out that I was in end-stage kidney failure, that I had less than 10% function, and that I'd be starting dialysis within 24 hours. So that was my crash start into the kidney world. And I say crash very literally. It was a big shock. I was so unhealthy that I ended up staying in the hospital for about 3 weeks just to get myself better. And I started doing hemodialysis at that time. So at that time, I was doing it every day to get myself back to a place where I was healthy enough to then go back home and come back to the hospital. So I did hemodialysis for about 5 months in hospital 3 times a week. And then I transferred to peritoneal dialysis, and I did that at home with a night cycler. So I would do that for 8 to 9 hours a night. And all through that time, my mom talked about becoming my donor. And, you know, it was a little bit scary to think about having my mom go through that process, but she was very adamant that not only did she want to be my donor, but that she would be. And, you know, as luck would have it, she did end up being a match for me. So we found out in the summer of 2009 that she would be donating her kidney on September 9th, 2009. At 9 a.m. So 9 is now our favorite number. We went through the process. That's my mom on the bottom left corner there. The two of us were at a Beyonce concert right before the surgery. We both went through the process, and it was incredibly successful. And as you can see on the right side of the page, those are all of the things that I have been able to do since transplant. So I worked in South Africa. My husband and I have traveled through Europe. And of course, we were able to get married in Dominican Republic. And if you want to switch to the next page, that transitions into why we're here today and why we're talking. So we actually were married for 7 years, and that's when we started discussing pregnancy and the possibility. And it was something that I hadn't heard a lot about. I knew a couple people who had been through the process, but really didn't know that it was a safe thing for me to do. or that it was even possible at all. So I had a conversation with my nephrologist and just asked a few questions if this was something that I could do. And he referred me to an obstetrical nephrologist who went through the whole process of, medications and what that looks like. And we were very excited to find out in July after I went away on a vacation at the cottage. I wasn't feeling great and I felt kind of like queasy on the dock. And, I've spent my summers up north. So, boats and water, that's very normal for me. And I was like, this is kind of strange. So came home on the Sunday and took 4 pregnancy tests and they were positive. And the one thing that was funny was my husband, when he went out to pick up the pregnancy tests, he actually also bought a bottle of champagne. He said, in case we were pregnant, we could have a glass of champagne. And I said, well, if I'm pregnant, I can't have a glass of champagne. So we did celebrate me with ginger ale and him with his champagne. So I had a very successful pregnancy. I was very healthy through the pregnancy. I often say, I felt pretty much the healthiest that I've actually ever been. My creatinine improved during my time while I was pregnant. And it wasn't until I was about 32 weeks that my blood pressure started to go up. And I'm sure Lisa will talk a little bit about preeclampsia. I did end up having preeclampsia at the end of my pregnancy. And so they decided that we would have a planned C-section. At 36 weeks, we were able to push to. And that brings us to the next slide. We ended up having a planned C-section, and I say planned, unplanned, because I went in to have the C-section on the Wednesday, went in on the Monday to get my COVID test, and they said, we don't like your numbers. We're going to actually do the C-section tomorrow morning. So it was planned / unplanned. She came a day early, but she was very healthy, 4 pounds, 10 ounces, a tiny, tiny little thing, but didn't need to spend any time in the NICU. And we were very happy to be able to take her home 5 days after she was born. And these are just some wonderful pictures of my mom in the center feeding her with a bottle of breast milk. And that was also something that I was able to do. I nursed my daughter in recovery, which was another first that I didn't think was possible for transplant recipients as well. But I am still nursing her now. And yesterday she turned 18 months old. So I have had an amazing journey. All of this wouldn't, of course, be possible without my mom as my living donor, but we've been very grateful to have such an incredible, incredible time with my daughter. And then the last page is just some more recent photos of her being a regular kid. So she's messy, she plays with bubble, she does gymnastics. And then my mom, of course, in the bottom right corner, my donor and, my daughter. I just really wanted to bring some hope to today in sharing that, yes, it is possible for you to have a healthy, successful pregnancy as a transplant patient and, to never stop when you think that something may not be possible. Always make sure you ask those questions because I would have never known that this was possible without asking my nephrologist. I'm going to turn it over to Lisa. And thank you so much, Lisa, for facilitating today and for your presentation. We're really excited to hear from you.
I'm excited to be here too. And that was just a wonderful way to start out this story. And I'm just going to go over a couple of brief objectives just to let you know about the Transplant Pregnancy Registry International. And I'm going to refer to that as the TPRI. We're going to list some pre-pregnancy guidelines for transplant patients and review some of the medications and recommendations for use during pregnancy. I'm going to also review our overall outcomes and also get into a little bit of one of the studies that we've done and how we can use the information that we collect. We're also going to go over some outcomes for fathered pregnancies and review breastfeeding after transplant too, which I was so excited to be able to do because 30 years ago when I started doing this, I could never tell anyone they could breastfeed. And now we can give people a little bit more information. So if you can believe it, the first transplant patient who was a female got a kidney from her identical twin sister, and she had a pregnancy back in 1958. And this is the first recorded pregnancy after kidney transplantation. A little bit different than nowadays because this recipient was not on any immunosuppression. She received the kidney from her identical twin sister. And interestingly, the donor went on to have 4 children. She has the 4 boys here. And then the recipient went on to have 2 children. So you can see from the moment women were getting transplants, this is something that has happened. And the TPRI has been collecting information for over 30 years. We were started in 1991, and we used to just study outcomes in North America, including Canada. And in October of 2016, we were able to now include pregnancy outcomes worldwide. We use a very simple method for data collection. We have an informed consent. For patients in North America, we have a telephone interview. We review medical records and sometimes interview the doctors. And we also perform long-term follow-up interviews with the recipient to monitor offspring and recipient health. So it's something that's very unique about our registry is that some people we've been talking to for 30 years now. Just to give you an idea, we do, as you can see here in this world map, most of our patients are from North America, but our reach has gone far and wide. And I think it's very exciting that we have patients from all over the world. This is just a few months ago. We're up to over 3,000 recipients. That includes men and women and all over the world. In this table, that's a lot of numbers. But what I really want to show is we have all different types of organ recipients. Kidney is the most, it's the transplant that is done the most also. But you can see our liver recipients are becoming larger in number, heart recipients, we have some lung, and then some combinations of organs a little bit less in our kidney, pancreas recipients, about 72. And also what I want you to notice is that the number of outcomes is greater than the number of pregnancies because patients do have twins and triplets. Not very often, but sometimes they do. And the number of pregnancies is greater than the number of recipients because patients do have more than one pregnancy sometimes as well. And we don't have as many men in the registry. I think it's multifactorial, is that we haven't found any problems with men fathering children, and men really don't think about being in a pregnancy registry. So we don't have as many men, but we know that there's a lot more men out there that have probably fathered pregnancies after their transplant. There are very good amount of resources out there for everybody. Two of those societies that I belong to, one's the American Society of Transplantation. We helped with a patient brochure, and I helped with another patient brochure from the International Transplant Nurses Society. And we also try and publish in major journals about transplant and pregnancy. And then we also write an annual report, which I'm happy to send to anybody at any time. And all of the information that I'm going to be talking or presenting today is from our annual report as well. So it's just something that's available and we're happy to send to patients or healthcare providers. This is a little bit older. We had a consensus conference back in 2003, and we published the outcomes of that in 2005. And I'm working on a new consensus conference this year. So hopefully in the next couple of years, we'll have some new recommendations. And these are actually based on a case report from the 1970s and just changed a little bit over time because we have more immunosuppression now too. But our general recommendation is good general health for at least 1 year after transplant. We know that first year after transplant, it takes your body a little bit of time to get used to your transplant, to get used to the medications you're on. Your risk for infection is much higher in that first year. And also your risk for rejection is a little bit higher in that first year. So we really want to make sure that kidneys function, liver function, lung function, heart function is all very stable, and you're on your minimal immunosuppression, because we know in that first year we use a little bit more immunosuppression than further out. So that's another recommendation prior to pregnancy. No rejection in the last year prior to pregnancy. Once again, that goes to stable transplant function. Originally, it was no high blood pressure, but I think this has been changed to more well-controlled high blood pressure and being on medication that's safe for pregnancy, and no or minimal protein in the urine. And that can go for kidney recipients and non-kidney recipients, because we know some non-kidney recipients can have some slight kidney changes due to the immunosuppression. So also, since then, I'm going to talk a little bit more about some of the immunosuppression, but we have found that mycophenolate is teratogenic. So we want to make sure you're not on mycophenolate prior to a planned pregnancy as well. So this is one of my favorite slides because it's very simple. Overall, generally considered safe to take during pregnancy are cyclosporin and tacrolimus, prednisone, and azathioprine. We know that mycophenolate mofetil and mycophenolic acid, brand names Cellcept and Myfortic, are contraindicated during pregnancy. And there's a few other immunosuppressive medications that we don't use as often, but we really don't have enough information yet to make definitive conclusions. That's with belatacept, which is a monthly infusion that some patients get for their immunosuppression, and sirolimus and everolimus. I think the data are encouraging, but just not enough outcomes yet with those other medications. So in 2007 in the US, the pregnancy category was changed based on TPRI data and additional information from the medical literature and the manufacturer. And this medication was given a warning that pregnancy should not occur while on this medication. So it's very important, if you're taking mycophenolate, to not stop it on your own, but to check with your doctors prior to planned pregnancy. And what this is really based on is that we looked at about 152 conceptions, and this was in all different transplant recipients. And what we had never seen before is this 50% live birth rate. Almost half of these pregnancies with exposure to Cellcept ended in a miscarriage or a non-viable outcome. And we had never seen this in the registry before. Our live birth percentage had always been about 75%, with miscarriages at about 20 to 25%. So this was really striking when we looked at this data back in 2007. And of the live births, 18% had a birth defect. And there was a specific pattern of this birth defect also, with ear deformities, cleft lip, and cleft palate. So it was very telling that it might be due to the mycophenolic acid products. And interestingly, these birth defects were seen in patients who were not on the calcineurin inhibitors, tacrolimus and cyclosporin. There were lupus patients who were just on the mycophenolate, and there were reports in the literature that those babies had birth defects as well. So this was much different than the data that I'm going to be presenting you, the overall data from the registry. And so it's very important that patients are aware that if they're on MPA, it is associated with higher incidences of miscarriage and birth defect, including a specific pattern of birth defects. So overall, what do we see? We've had patients as far back as having pregnancies in 1967 in our kidney recipients, all the way up to a modern time. This was from our 2020 annual report. So, that's why there's not conceptions occurring after that. And what we see is that most patients, are about in their early 20s when they're first transplanted, a little higher in kidney pancreas recipients, because we know diabetic complications can take a little longer to manifest over time. And most of our patients are waiting that 1 to 2 years after transplant before conceiving. This is a little bit longer in liver recipients because many of these patients are younger when they're receiving their first transplant. These are numbers here, these unplanned pregnancies. They're better than when I first started, but all pregnancies after transplant are considered high risk. So I would really love to see the number of unplanned pregnancies coming down. You'd be surprised at how many people I talk to that tell me, oh, they told me I never could have a baby after my transplant. And it can happen, as we've seen. So we do, especially in our kidney recipients and kidney pancreas recipients, have a very high percentage of drug treated hypertension during pregnancy. And in the general population, it's only at about 5 to 10%. So we're talking about almost 5 times higher in kidney and kidney pancreas recipients, and a little bit lower in liver recipients because they do not tend to have as much high blood pressure as our kidney recipients. Diabetes is also higher than the general population, but it's been pretty consistent in our population. And we know that some of the medications that patients are on can cause diabetes after their transplant. And we've only had a couple patients who required some treatment during their pregnancy that required insulin. So very small, the pancreas usually is able to keep up with the demands of pregnancy. And like Candice mentioned, we definitely see more preeclampsia than the general population. It's hard to get an exact number for preeclampsia in the general population because it can vary by age and by race. So we know that this is much higher though than the general population. It's quoted kind of like hypertension, that 5 to 8%. So really talking, much higher than the general population. And it occurs for a variety of reasons. And we're not really sure why transplant patients are more prone to preeclampsia than the general population. And also, we do see some rejection during pregnancy, but it's very rare. And usually, some of the patients have chronic rejection that might have been diagnosed before the pregnancy. So we know there's really no treatment for chronic rejection. And the few acute rejections we've seen can be treated, but you are at a higher risk for graft loss if you do have a rejection during the pregnancy. And I think fortunately, we do not see a lot of graft loss within 2 years of pregnancy, which is kind of a arbitrary amount of years after the pregnancy that we thought that the graft loss might be related to pregnancy events. But we really haven't seen a high incidence of graft loss after pregnancy. And what do these babies look like? So we have over 2,300 pregnancy outcomes with 1,700 live births. And as you see, that's about 75%, which is what we've seen all over the time of the registry. And the gestational age of the babies is about almost 36 weeks. So we do have a high percentage of preterm births in all of our patients and a little bit higher in kidney pancreas. And we can't quite figure out why that is. It's a little bit lower for our liver recipients, but they have usually adequate kidney function. So we think it might have something to do with that. And also, liver recipients take a little bit, are not on as much immunosuppression as our kidney recipients. So really, it might be related to that as well. So we do see a high percentage of preterm births and low birth weight as well with our patients. And it might be due to the high rate of preeclampsia and delivering early. I think someone called it obstetrical unease. Some patients just, everything's going well. Let's just have the baby out. Everything's been going well with your transplant and let's not run into problems. So a lot of different reasons. We do see a high percentage of cesarean section in our transplant recipients. An obstetrician that I've worked with for years has said, really, there's no indication just because you've had a transplant that you have to have a C-section, but we still do see a high percentage, maybe due to preeclampsia, maybe due to preference of patient and physician, but it is a major surgery. And we know patients on immunosuppression are more prone to infection. So it's something to consider when you're talking about a delivery plan with your doctors. And overall, we really see a low rate of birth defects reported. This includes everybody, even those with mycophenolate exposure. And in the general population, the major malformations are expected between 3 and 5%. So, really similar to that of the general population. And we really don't feel like we have a high percentage of neonatal deaths as well. And it's really something that over time has remained about the same. And we really don't see a lot of neonatal deaths. And I think that's due to the good prenatal care that we have now and the good neonatal ICUs as well. I usually get the question, can I have a baby? Yes, you can. And after that first one, I hear a lot of times, could I have another one? And when I first started, many patients would tell me, oh, my nephrologist told me I could have one, but not to risk it for any more and only have one. And we really wanted to look at this a little closer to see how patients do with a second, third, or more pregnancies. And as you can see, there's not many who've had fourth or fifth or sixth or more pregnancies, but there are many that have had a second pregnancy or a third pregnancy after their transplant. So let's look at those outcomes as well, because I think a lot of people have that initial question, can I have one? And then let's see if I can have another. So very similar outcomes overall, younger age, getting older as you have more. Obviously, you have to have some time in between. We do have a high percentage of living donors in our registry, and we are predominantly Caucasian for self-identified race. We still see unplanned pregnancies, even in the second and third. And like I said, this is something I think just more education we need to know about planning a pregnancy is best. So looking at the comorbidities over time or over the different numbers, we do still see a large number of having hypertension before pregnancy. It goes up a little bit more during. Similar rates of preeclampsia overall. And you can see that there is a statistical difference between the the different pregnancies, but with diabetes, no statistical difference, but very similar percentages or incidences of diabetes during these pregnancies. So just something to be watchful of. And I know our obstetricians are very good at monitoring patients, or especially our transplant patients during pregnancy. So, how do creatinines look? A very good between the first and the second and third. So, really, no statistical differences. We found overall, if you have good, stable transplant function prior to a pregnancy, you're probably going to do very well. And once again, those very low rates of rejection and graft loss within 2 years of delivery, even after multiple pregnancies. What do the outcomes look like? I think overall very good. That live birth percentage in the 70s and low 60s, a little bit different for six or more. I'm not sure why that is. Overall, that miscarriage rate about 20%. And we have a very small number of stillbirths, ectopic, and terminations. And I think here there was a little statistical difference between live births, but I think a couple of these patients might have had mycophenolate exposure as well. Just a little bit different with that six or more. How do the babies look? Overall, getting a little bigger as we go on. So there was a little bit of a statistical difference between one and the six, but I think this happens overall in the general population as well. Babies usually get a little bigger and born a little bit later as you go up. And same with the birth weight. And interestingly, though, the preterm birth stayed about the same throughout this and a little bit less low birth weight as you got more outcomes. But overall, very positive outcomes with all of the babies that were born. And looking at birth defects, once again, with this smaller number, there was really no statistical difference. So, really remained in that area where we expect some birth defects. And once again, cesarean rate much higher and than we see in the general population. Something to think about, like I said, when you're making a delivery plan with your doctor. So, in summary, almost 50% of our kidney patients will have more than one pregnancy after their transplant. Not always two live births, but the majority do. And these successive pregnancies are not associated with adverse maternal, transplant, or allograft, or newborn outcomes. There seems to be a little bit of a natural selection towards stable pre pregnancy transplant function and non-transplant associated obstetrical complication as the pregnancy number increases. There continues to be a high rate of unplanned pregnancies. If it were me, I would love to see that number be zero. It's not always going to happen. We know even in the general population, about 50% of pregnancies are unplanned. And women with good, stable transplant function and overall good health should not necessarily be discouraged from having additional pregnancies, but appropriately counseled. And I think it's really important to ask questions. And also, I'm going to put a plug in for the registry is that the more outcomes we have, the more we can do studies like this and draw conclusions and let people know what the hard data is and not just an opinion like I heard 30 years ago. Oh, you can have one, but only one. So, what about breastfeeding after transplant? Like I mentioned years ago, when I first started doing this, I could never let patients know that there was the possibility of breastfeeding. However, based on some recent studies that have shown recipients taking those same medications that I said were safe to take during pregnancy need not be discouraged from breastfeeding. So prednisone, azathioprine, cyclosporin, and tacrolimus, kind of the cornerstone of immunosuppression that patients are on after transplant. However, there's limited data regarding breastfeeding while on mycophenolic acid products, salseptin, sirolimus, everolimus, and belatacept. And our thought really is if the MPA is teratogenic and can cause birth defects, it's probably not good to breastfeed while on that medication as well. And we really, once again, just don't have the number of outcomes to make any definitive conclusions about breastfeeding while on everolimus or belatacept. However, once again, the number of outcomes are accruing over time. So hopefully, in the next 30 years, we can make some stronger conclusions about that. And I just love to show this slide because it really shows how things have changed over the years. So this is a 20-year trend in breastfeeding practices with mothers with transplants. So this is anyone who said yes to breastfeeding. It could have been for a couple days up to longer, like Candice, up to 18 months. Or I know we've had some people breastfeed their children, up until 2 years and greater. But you can see here in the early 2000s, only about 10% of our patients were breastfeeding. And now we're up to almost 70% of our patients are at least trying to breastfeed. And it was really critical based on this a couple studies I'm going to show in 2014 that things really changed around. So the first study was that tacrolimus levels in blood and breast milk were what they were able to look at was that it was less than 0.3% of the mother's weight adjusted dose. So if you're taking, let's say, 6 milligrams total a day, that's 0.3% of that the baby would be even exposed to. And if you think about it, the tacrolimus has to be metabolized by the mother's liver and then get through into the breast milk, and then the baby's going to metabolize it. So overall, very, very low amounts. And there was another really interesting study, and it looked at 15 infants who were exposed to tacrolimus during pregnancy, and 11 were breastfed. And the amount of tacrolimus levels, there was no difference between those that exclusively breastfed and those who are not. So I think this is a really pivotal study. And you can see it was published in 2013. And we really saw that jump in the registry in 2014 of patients being able to breastfeed. And I think it's really important that these studies are out there and that patients are able to access these because there's so much information that they can gain. And it was really, I think, telling that clinicians were able to now say that it's probably okay that you breastfeed. And what about our dads? So, like I said, I know we don't have as many outcomes for fathered pregnancies as we do in females, but I think you'll notice that outcome differences are quite striking. So we still have some mycophenolate exposure in our males. And you can see that the mean gestational age is very close to the general population. Our mean birth weights are much higher than we see for female recipients, and percentage of birth defects among the kidney, liver, and kidney pancreas recipients are right what we would expect with the general population. So, because there were questions about females having babies with mycophenolate, we wanted to look at the male outcomes. So, we had about 295 pregnancies that were exposed to either Cellcept or Myfortic, and we have quite a few more that were not exposed. But I think the conclusion of this study was that there was no statistical differences between the male fathered pregnancies with exposure to MPA and those unexposed. So we see no problems with men fathering a child while on mycophenolate. Live birth percentage, 90%. Neonatal death percentage, the same. Miscarriage rate, no statistical difference. No difference in the gestational age or prematurity or birth weight or the birth defects. So, really, we were able to conclude that overall, the outcomes of pregnancies fathered by transplant recipients are similar to that of the general population. And currently, the TPR data does not support the avoidance of MPA for male transplant recipients considering pregnancy. So, this isn't for females, this is all for males, but it was very positive outcomes that we've been able to report because we have had questions about does our male recipient have this discontinued prior to fathering a pregnancy? So, overall, in summary, recipients of childbearing age should be counseled regarding the feasibility and timing of pregnancy after transplantation. Like I said, we still have quite a few unplanned pregnancies. And I've heard many patients say, oh, they told me I could never get pregnant. When with a successful transplant of any organ, usually fertility returns very quickly after transplant, and there is the potential for pregnancy. Pregnancy and maternal outcomes vary greatly based on multiple factors, especially on the type of organ transplanted. And there's really pre-pregnancy transplant function kind of rules how things go. And there are other medical conditions that can affect pregnancy outcomes also. All pregnancies after transplantation are considered high risk due to increased percentages of high blood pressure, preeclampsia, and prematurity. And it's really important that a post transplant pregnancy be managed by a multidisciplinary team. You heard Candice talk about being referred to obstetrician who specialized in nephrology. So we're really getting these specialized groups, and it's important to kind of be a good advocate for yourself during a pregnancy because you'll have multiple teams work following you to try and get them organized and coordinated. So the transplant team is following your tacrolimus levels, and then the obstetrician is following the fetus, and that the transplant team is making sure they're talking to the obstetrician so you're not getting different opinions. So that's the summary of my talk. I just want to let you know that we have some stories on our website that you can easily participate. We have a short questionnaire that you just fill out. And then, if we can, we'd like to talk to you to get information about your pregnancy. There's publications that you can request. And we have some news and events. I'm actually going to put this webinar up probably since it's being recorded on YouTube, which is just fantastic. I'd like to highlight Faith here. She used to work with us and she had a kidney pancreas transplant. It was her 30th anniversary this year, and these are her two girls that she had after her transplant. I also just want to acknowledge my two colleagues, Dot Klinevsky and Carolyn McGrory. Carolyn has actually been with the registry longer than me, and we're a small but mighty team. And I also just want to recognize the founder of the registry, Vincent Armenti, who had the forethought to think of this over like 32 years ago. And unfortunately, he passed away in 2014, but I'm trying to keep this going as long as possible. So this is my contact information. I'll leave it up for a few minutes. And I think what I would love to do now is have a discussion and answer any questions that you might have. like I said, even if I can't answer it now, I can always email you or get back to you. So I think I will, if I can do this gracefully, stop sharing and maybe see everybody's faces and we can answer questions now.
Amazing. So before we go into questions, I just want to say thank you so much, Lisa, for presenting all of this. It definitely gives people a good overview of what to expect. And I think it also gives people hope that, not only is pregnancy an option for people who have been transplanted, but it can be done in a very healthy, successful way. Um, so thank you so much for that. I want to echo what some of the things that you've said today. For anybody who's listening today, one of the things that I think we really want you to know is that yes, you can have a family. And as Lisa said several times today, the best way forward is to plan these things and to talk to your physicians and talk to your specialty teams because they have ways that they can guide you and make sure that this is a safe process, not just for your child, but also for you and your transplant, so that at the end of this, everyone comes out in the healthiest possible way. And I'm going to add a selfless plug here. We do have our Living Transplant podcast. Our season 3 is live. And our first episode of that podcast is called Yes, You Can Have a Family. And it has Dr. Anna Matthew from McMaster, who is an obstetrical nephrologist. And she goes through a lot of those questions that we had about what are some of those planning things that we need to discuss, like medication and what is the best timeline to have a child, and all of those questions that you may have for a nephrologist. She does a really great job of covering some of those things and discussing what that pre-pregnancy planning meeting would be like with a nephrologist. So it's also a really great thing to check out. Again, it's the Living Transplant Podcast season 3. And I think with that, it would be great if we could open up if anyone has any questions. And if feel free to turn on your video, to type in the chat, whatever you feel most comfortable with.
So there are a couple questions that I can, I think, go over. And someone asked if graft loss means they need another transplant, and that's yes. So I think, kidney recipients, it's a little bit different than liver because we do have patients, some patients have to go back on dialysis. We know that kidneys are, lasting longer and longer, but they're not always lasting forever. So sometimes there is that need for a second transplant down the line. So yes, graft loss does mean that their kidney is not working and they're either on dialysis or had another transplant. And we really don't know about the miscarriage rate in the healthy population. It's really hard because some women might even just have a missed period and not even know that they were pregnant. I think what we like to look at in the registry, especially when we think about mycophenolate outcomes, is just the difference that we saw in the registry before mycophenolate was approved and used compared to what we saw with mycophenolate exposure. And that was really, what prompted us to kind of say, well, this might be something going on with this medication. And then the reports in the literature as well of the malformations and the specific pattern they had. Someone just put pruritus in the questions, and I'm not sure. We don't see a lot of what's called cholestasis of pregnancy in our kidney recipients, but it is higher in liver recipients compared to the general population. We're not sure why that is, but luckily it does not affect breast function. And just like in the general population, if you do get cholestasis and have had a liver transplant, once you deliver, it usually goes away and there's no problems. But we do see that a little bit more often in our transplant patients. Most people, their creatinine goes down during pregnancy because your GFR increases and your blood volume and fluid volume increases. So usually in transplant recipients, we see that kind of normal dip and then back to baseline postpartum as well.
And just as a fun fact, I always say that Clementine, my daughter, made me have a healthier transplant because during pregnancy, as you mentioned, my creatinine went the lowest it's ever been, and it's actually stayed very close to that level. So I always say it's another little thank you to my daughter for making my kidney function a little bit better. Of course, not the same with everyone, but my creatinine did get better postpartum as well. So that was interesting to see.
And what we usually see is it returns to baseline. And even if patients do have the increase during pregnancy, and usually it might land a little bit higher, but not necessarily, to where it's not functioning.
How many
Yeah.
percentages end up with a higher creatinine post delivery, for example,
No,
6 months later?
yeah, I don't have that statistic. We haven't looked at that. So that's something very interesting to look at. Thank you, because that this is how I get my ideas for some of the studies we do. Is when people ask me a question and I say, "Oh, I don't have that, but that would be a great study for next time."
Awesome. And
Uh,
another one is, how long after you deliver do you return to medications like Myfortic?
So that is variable. It depends on if a patient's breastfeeding. Usually they won't start it back up until after you're done breastfeeding. Some nephrologists will leave patients off of it if they want to have that second pregnancy, if they're stable instead of going back and forth. Sometimes if patients have, a problem with their transplant after the pregnancy, the nephrologist might recommend going in on it sooner. I think every case is completely different, and it's something to discuss with your nephrologist. If you're planning a pregnancy, to say, okay, if this one goes well, I know I might like to have a second one. What are your thoughts about staying off of it in between or going back and forth? Or you might just have to wait and see to see how your transplant does during that time also.
Mhm. The next question is, have you found that people who have been on mycophenolate for long periods of time, example 16 years, and come off it to ASA have had a hard time conceiving?
So that would be another good study. We haven't looked at, so we do collect that information of like when they started the gofenolate and how long they were off of it before their pregnancy. Overall, patients, about 20% report having some fertility issues in our registry. It could be higher because we only hear from people who've had a pregnancy. So there could be patients out there that have been trying and never were able to conceive. So I don't have the exact information for that. But overall, we have seen that patients are able to conceive after all different time frames of being on all the medications. And if you think about it, some of our younger liver patients were transplanted when they were maybe one or two, and they've been on immunosuppression for 20 years and they have still been able to conceive. And that's what I also want to mention is that we are a voluntary pregnancy registry. So we're not mandated by the government. We know that there's probably a lot more pregnancies out there that we don't capture. It's been a pretty high number and the most of any registry.
So, do you need to stop other medication besides anti rejection medication during pregnancy, for example, with a liver transplant?
There are some blood pressure medications that are not recommended to take while you're pregnant as well. They're all different because there's a wide variety of hypertensive medications. So that's another reason why it's so important to plan a pregnancy because you could be on another medication not related to transplant that might not be the best for the fetus. So that's another reason to really kind of have that consultation with an obstetrician, your nephrologist, or hepatologist prior to becoming pregnant.
Another question is, do you have any stats on the effects of mycophenolate on egg effects or egg quality for IVF?
No, we do not, unfortunately. I mean, we have had patients who've been on mycophenolate and have done IVF, but I think for our registry, that would be a little bit harder because there aren't so many people that have done IVF and not everybody knows their egg quality. Some people don't, and we're relying on patients to remember. what they were told. So that would be a little bit harder to figure out.
Would there be a guidance on how long to be taken off or when to change from your medications prior to conceiving?
So, if you polled probably 10 nephrologists, that you might get 10 different answers from this. At least 6 weeks is the package recommendation. And I know some nephrologists, because you're changing that medication and they're not equal. Azathioprines and old medication. Back in the 70s, we only had azathioprine and prednisone for immunosuppression before we got cyclosporin and tacrolimus in the early 90s and early 80s. Some nephrologists might want you to be off of it for like 3 months to show stable transplant function prior to pregnancy to make sure that you're not going to have any problems on the azathioprine. So it could be anywhere from 6 weeks up to 6 months, I've heard. It really varies depending on the patient and the nephrologist.
That's great. Do you have any studies on transplant recipients who become pregnant after 35 years old? Are there any increased risks?
I do, because
Mhm.
this was a question we got asked before. And I think the risks are similar to that of the general population. We know older moms have more hypertension. We know that older moms have more preeclampsia. So kind of those same things you see in the general population. We did this in kidney and liver recipients. So if you'd like to email me, I'd be happy to send you that specific study and we could go over the outcomes. But overall, the older moms, I think we broke them down into like 20 to 28, 30 to 35, and then over 35. The younger patients tended to have less planned pregnancies, interestingly, and the older moms more planned pregnancies. But I'd be happy to send that specific study that we did out to you.
That's great. And just to let you know, LP, I am one of those, the 35 plus group. And from my nephrologist, basically what they were saying as well is very similar to the general population with increased risks. So he went over that with me and talked about preeclampsia and birth defects and all of those things. So, all of these questions, I would suggest if you're interested in doing like a pre-pregnancy talk with your nephrologist, to just sit down and write down a big list of questions and have them ready when you go, because often when we get there, we hear things and we forget to ask the questions. So writing them all down are absolutely a great way to remember what you want to ask. And just to warn you, if you are in that age group, you're going to be called a geriatric pregnancy, which nobody likes, but we've put petitions in to change the name and it hasn't happened. But anyways, yes, those are great questions to bring to your nephrologist or your specialist. And write them down, because it can get overwhelming sometimes when you have 5 or 6 questions in your head, but then all the information comes at you and you can forget it easily. That. So are there any other questions that we can support people with here in the chat? I'll do one final call out to see if anyone has any more questions. And if not, I think what we will do is I'll make sure to get all of Lisa's information and put that in the description. So within the next day or two, we will have this recording up in full on YouTube on our Center for Living Organ Donation channel. And then we'll share that link with Lisa as well, so that everyone can watch this if you want to rewatch it as well. We'll share our information and Lisa's. If you have any other questions, you can feel free to email us as well at livingorgandonation at uhn.ca. And then I can also share Lisa's information again as well with anyone who wants to first add yourself to the transplant registry, which please do. I'm part of it and I'm trying to get other friends to join as well. And then secondly, if you have any questions for her as well. So thank you so much, Lisa, for all of this incredible information and for taking the time today to be with us. We really appreciate it. And we're seeing all of these thank yous from the chat as well from everyone who has been part of it. So we're very grateful for your time.
Yeah, oh, you're welcome. It's my pleasure. It's as you can tell, it's my favorite thing to talk about.
Oh, that's fantastic.
I'm a huge advocate for patients, and I try and get the right information out there as much as possible.
Amazing. Thank you so much.